Well, doctors don't like doing revisions. They're hard. It's hard to meet patient expectations. Revisions are complicated, as I said before, because you're operating on scarred planes. Some of the planes and anatomy have been distorted completely, so it's not like first-time surgery. There has to be an understanding between patient and physician about what realistically can be accomplished. Because the primary reason patients are unhappy with revisions is that they have an expectation that they'll be exactly as they were before the primary surgery that led to the problem. And unfortunately, that's not always possible. So what patients need to expect is a 50% improvement, and anything above that is a gift. But I believe that's realistic. Now, when I say 50% improvement, to be honest with you, I'm undershooting. I'm not in this because I want to be good 50% of the time. But the problem is we just don't know till we get in there, because I don't know how bad the anatomy is distorted. I don't know how the blood vessels and vasculature and blood supply has been affected. Maybe they had one surgery before, maybe they had 10 surgeries before. All those play a factor. Everything is done to make them as close to where they were as possible, within the realm of what reality is. So it really requires the evaluation to come to the answer. It's a vague question and I give a vague response because if on my examination of the patient, I find that the tissue planes are not overly scarred and there's a good blood supply and tissues move around nicely, I can get them very close to where they were. But on the other hand, some patients have had 7 or 8 surgeries already and the tissue isn't quite the same. So I think the key is the evaluation coming into the office. It can't be done with a conversation on the phone, and it can't be done by looking at pictures or just talking over the internet on a Skype. It requires that personal interaction so tissue can be felt. So here's the other issue. I never just do surgery. I'd rather do nothing than potentially not meet an expectation or make it worse. And the reality is I'll evaluate a patient often and just say, I can't make this better. I don't think you should have further surgery. Revisions have what I call the domino effect sometimes, where there have been a number of surgeries performed and it really can't be improved much with surgery. Maybe fillers are the best option then, but if you keep operating, things get worse, kind of like the dominoes falling. The most common reasons that patients see me for revision surgery are eyelids that are retracted. That means pulled down. And so the lower lid is lower, the outer part of the eye is rounded, the shape of the eye is changed. Probably the next most common reason I see people for revisions is the outer corner of their eye, where the upper and lower lid meet. This area right here, it's called the lateral canthus. That area has been distorted because it's been cut during primary surgery. And now it looks different, feels different. Patients often say, I just don't feel like myself, I'm uncomfortable. I have a personal opinion that the lateral canthus is involved in so many functions for the eyelid that if you could leave it undisturbed, leave it undisturbed. So revising that area can be tricky too. Finally, the next most common reason I see people for revisions is because they can't close their eyes. And typically that's related to excising too much tissue from the upper lid, and there's a variety of ways to address this, not the least of which is fillers. The reason I emphasize fillers is because if patients can do something without cutting again, that is really a nice way to show them that there's an improvement, things can get better, and we can delay surgery, especially in patients that have been so traumatized by their initial surgery.